Good afternoon, everybody, or morning, depending on what time zone you're in or where you may be. Appreciate you joining us today. I'm going to jump into our presentation. This has been a hot topic for a while, and especially with all the news surrounding, not directly the issue that we're talking about today, because we're mostly looking at payer disputes today from the provider's point of view. But of course, last fall with the shooting. This was a big topic nationwide, certainly all over YouTube and other social media. There was discussions about payers and treatment of both patients and the users of the healthcare system, and certainly our providers and the folks that I'm used to working with and representing are working with third-party payers all the time and having some disputes. And we're going to jump into that issue. I've been wanting to cover this topic for a while. We've covered some various parts of this, and we'll probably do some spin-offs of this in the future. So I welcome your questions and any input you have, including any particular topics you may want to have us cover in the future. Here's the agenda that we're going to jump into. You can see we'll cover, essentially go through the life cycle of how an audit starts and what you can do ahead of time, what you can do to prepare, what you can do when you get a letter requesting documents. That's usually the start, the initiation of the audit, potential recoupment. And then we'll do a discussion towards the latter part of the seminar today, talking about how you can respond to those letters. We'll spend a lot of time focusing on that, and also challenging findings and the tools that you have at your disposal. All right. Got a couple quotes throughout the slides here, a couple interesting statistics. This is from the U.S. Surgeon General. Administrative burdens such as insurance authorizations and billing are driving talented healthcare workers out of the field. I think we all inherently know this. If you work in the healthcare industry, I certainly know it because my own personal physician and longtime friend, longtime physician, and his wife, who is also a longtime physician, retired early. They're about my age, and just through burnout, decided to walk away from their healthcare practices, very busy practices that they had. And it all had to do, it had nothing to do with the work and dealing with patients. It all had to do with administrative oversight. What's the biggest administrative burden? Dealing with billing issues and payers. When folks do the work, you're passionate about the work typically, same as in any profession, including law, like what I do. We often enjoy the quality time that we have with our clients, enjoy the challenges that arise. We want to get paid for the work. That's primarily the issue that I hear over and over, is struggles that folks have getting paid, and not only getting paid, but keeping that payment and not having to jump through a bunch of administrative hurdles in order to retain the payments. Today, we're seeing increased audit activity, both from CMS, from private payers, of course, AI-driven models, and the providers feel targeted by the system. There's a professional toll, an emotional toll. There's obviously pressure to deal with situations, especially payment issues that arise retroactively. You get a letter, you get some type of request for information from something that happened a few months ago. You've got to go back and gather information. Today, we're going to talk about how you can prepare for that in advance. Of course, as I mentioned earlier, the United Healthcare shooting, whatever side of that you're on, it was a big political or a big public discussion going on about the American healthcare system in general. And really, if you think you have a strong position in that argument, I would encourage you to try to look at all sides. I looked at some additional material on that, and I was quite surprised at some of the information when I really kind of put aside the talking points from the different political parties and just looked at it from an independent point of view. I would love to do a discussion on that and maybe even have some guests. What some of the information when I tried to look at it with an open mind, it would probably surprise folks where I land on that on those issues. Of course, the operational impact on practices. I've worked with one client dealing with several clients dealing with large audit and recoupment demands. One client, it may put them out of business. We're working through some issues right now, but ultimately, because of it has nothing to do with the work or the quality of work. It has to do with technical issues in an audit, recoupments, extrapolation arising from recoupments. And when you take a small provider who's maybe works in a solo practice and has been doing this as a career, making a good living, but not a great living, and then suddenly you're looking at $1 million audit recoupment demand. That's the type of thing that can drive somebody out of business, can drive somebody into bankruptcy. We hear a lot about patients and folks being forced into bankruptcy. I've heard many statistics that suggest that the biggest cause of bankruptcy filings in the United States is healthcare bills among patients. But what about some of the demands on the providers? If you get $1 million demand, are you prepared to pay that and to deal with that if that comes from a recoupment? I think a lot of folks would have a very hard time with it. And I have one client that I've been working with that we're hoping he doesn't go out of business. Of course, there's other risks with audits, not only the payment demands, but reputational risks. Nobody likes to be told or hear that the work that they did is worthless or that what they did wasn't medically necessary. And again, this isn't just for healthcare, but that's what we're focusing on today. This is in any industry, really. Certainly, if you are a lawyer or if you're an accountant or you are in some other type of professional practice and you have an issue with billing because the allegation is the work that you did has no value or is of little value in healthcare, that term is typically comes down to medical necessity. We'll talk about that some more. If you're dealing with a medical necessity issue, not only does it have payment implications, but it also has implications on your reputation and on your ability to get credentialed with insurance providers, your ability to obtain privileges, perhaps with hospitals and other organizations, and your ability maybe to your ability to work essentially in the industry. So these are all the types of risks that we're dealing with when we talk about audits. It's a huge issue. You're at a structural disadvantage as a provider. You're not writing the contracts with payers. The payers are writing the contracts. They have the big lobby organizations. They're the ones with the not only contracts, but all the stuff that gets incorporated into the contracts, the additional terms, the guidelines, LCDs, other mechanisms that are being used to guide the practice. And the complaint among providers is that it's not being driven by what's most beneficial for the patient, and what's medically necessary is determined by the professional who should be making that decision, and that's the provider. It's being driven by the parties who are paying for it, and they don't always have the best interest of the provider or the patient in mind. They're trying to do this to maximize costs. And in fact, some of these companies have a duty to try to do it, or not maximize cost, to minimize cost and maximize profits, I should say. And they have oftentimes a fiduciary duty to do that. If a company is a publicly traded company, I don't mean to pick on United Healthcare, but let's be real. If you look at United Healthcare's stock over the last 10 years, it has skyrocketed. And the reason for that is that the company, from a shareholder perspective, has been well run. If you were an investor in United Healthcare back in 2014 and you looked at your portfolio today, you'd be pretty happy with the results. But what about the market that company is supposed to be serving for patients and the folks that they're supposed to essentially be partnering with, who are the healthcare providers? What would those folks say about it? You're at a substantial disadvantage if you are negotiating with one of these companies. The contracts are designed to maximize profits. That's what it amounts to. They couch it in terms of not abusing the payment systems and limiting action to what's medically necessary. But we'll see several examples of where what appears to be overreach by payers. Regulatory complexity. If anybody who's had the occasion to go through, in particular, a Medicare audit, there's several stages to that. There's a lot of technical issues. And what's interesting about it is if you ever go through it, you'll find that the rules seem to be flexible for the auditing side, but the rules are completely inflexible for the providers who have to respond. And it's the auditing side who writes the rules. So they write the rules, they get to make exceptions, they get flexibility, but the payer side or the provider side doesn't have that same flexibility. So what I'm going to try to do today is help you shift your mindset and become more proactive. And I'm going to give you some tools to both prevent audits, prevent them from getting out of hand, understand how to respond to letters when you get them, understand how to keep good documentation, some of the common errors that you can avoid, and what to do if you in fact go through this audit process and it results in a repayment demand or a recoupment demand, and what to do with that. This is an interesting statistic from CMS. Over $1.9 billion in improper payments were flagged by Medicare in a single year. Uh, this is 1 year. This is probably the biggest area, obviously, in the news right now. We're hearing about DOGE and cutting government spending and waste. This is one of the targets that has been a target for years, is healthcare spending among federal government. But it's not just Medicare. Medicaid, state agencies, and in private payers, I've seen more and more providers, healthcare companies that are audited by private payers who come up with all sorts of reasons to not only audit records but deny payment. Things as simple as illegible signatures, if you can believe it. And we'll talk about how to deal with that and what you might do to avoid it. All right, first thing is documentation. Good documentation from the beginning. A lot of EMR programs are set up to provide documentation, but make sure you're using the program properly and you're gearing it from patient to patient in a personalized way. Of course, a lot of the systems are set up to use the same terminology when you are providing services, and if you are a specialist, that terminology is going to repeat over and over. But document cloning is one of the big targets of audits, both government audits and private audits. You want to make sure that your documentation is able to justify the procedures for the particular the folks that you are providing services for. You also want to be sure to align your documentation with LCDs and any other payer guidelines when they are available. Watch bulletins that come out. Oftentimes the bulletins from regulators or even from insurance payers will have information that discusses what the big issues that they're seeing in what they call typically fraud, waste, and abuse. What are the issues that they're focused on? And this will give you an idea of what kind of issues that they are targeting for folks who stand out. So this is the first spot, is understand how to keep good, proper documentation from the beginning so that when you get the audit or the record request several months later, you're able to provide good documentation that covers you, and you have the information available to you to answer questions as they arise. Common pitfalls that you want to avoid, obviously, incomplete records. It may be tempting to you're rushing through your day. You're trying to provide services for all your patients, the folks you're providing services for. Simple things like signatures that aren't completed. Signatures, it's a good idea, by the way, to keep a signature log. If you have, for instance, referrals and you need to keep documentation of referrals from other providers, and that's part of what you need to get paid, keep a signature log of folks who are signing off on these. So you can go back and refer to it. And if necessary, we'll talk in a little bit about how you might correct signature issues. Lack of start and stop time for certain codes, vague terms. I'll give you an example on start and stop times. A client of mine had one of their providers who was doing most of their appointments through telehealth. And of course, some of these telehealth systems keep track of when you start the session, when you end the session. So the telehealth system keeps track of that. But if that doesn't talk to your EMR system and you don't have start and stop times, that could be something that you get dinged for. The problem that we had in one situation was start and stop times that were being recorded by a provider that did not align with the systems in the telehealth system. Well, that creates a problem. If you have longer start stop times in your records and the EMR system or the Zoom system that you're using, I say Zoom, but the conferencing system for your telehealth that you're using does not align with your billing records, that could create a problem in the future. So there's some very easy things that you can go through and make sure that different systems align properly so that your records are consistent. These are the type of things that regulators will seize upon if they routinely see uh, uh, 30 minutes being billed for something that in a telehealth conference is only 24 minutes. If you don't have a good explanation for that, that's going to create problems for you. Audit proofing techniques here, and these slides you can go back, they're pretty detailed, so I'm not going to cover every word that's on every slide. But obviously more specifics in the records and the specifics tied to the particular patient. So again, you're going to have certain terms that overlap and that repeat over and over, but to avoid the cloning issue, you want to make sure things are specific to your patients as much as you can individually identify patients in the records, and then have the treatment discussion, then you want to include both of those. Yeah, the italicized, let me go back to that section. This is a good outlook. Document as if you're not like you're looking at it now, but as if you're going to have to go back and look at this in 2 years, or someone else is going to have to go back and look at this in 2 years. Are you going to understand what you did and why you did it? Are you going to be able to explain medical necessity? Can you explain it in layman's terms? Can somebody else looking at it easily look at these records and say, oh, I see. And I'm not necessarily talking about and someone involved in an audit, an auditor or somebody from the payer side. But if you get an expert, if we get involved in an audit and there's a recoupment and we have an expert that goes back and looks at your records from 2 years later, is the expert that we retain going to go back and be able to read your records and say, oh, okay, I can understand why you did this, and very little external explanation is necessary. Always keep that in mind when you're looking at the records. And some folks have somebody else who goes back and reviews their records to make sure that that they cover these issues. If you're in a big organization, you probably have that resource available to you. But if you're not in a big organization, just keep in mind that if you get whacked with some type of demand for a huge payment that you're not expecting sometime in the future, folks have insurance and they're very concerned, obviously, about lawsuits. And we talk some about lawsuits in some of the seminars that I've done, and some risk mitigation that you can engage in. Of course, everybody has, most people have some type of liability insurance for claims of negligence. But probably the bigger issue that I see in my practice, even more than that, something that's more common, are these huge payer demands, anywhere, oftentimes hundreds of thousands of dollars, sometimes over $1 million, depending on the size of your practice and the scope of the demand. Internal billing, coding, and compliance. I just sort of mentioned this. You may want to get somebody to go back and look at your records, and maybe have somebody come in and do a mock audit. Get somebody who's familiar with billing. There are folks available, consultants who can come and do this. We sometimes walk through, do a mini version of this in our firm. We'll work with clients. I have a great, somebody that works here in the office side by side with me, has been doing healthcare billing and coding and dealing with these issues for over 25 years in practice. And that's why we brought her on board, and very knowledgeable. And we can often identify some of the simple things that will keep you out of trouble. Coding software is a big issue. I've talked a little bit about the cloning issue that you want to avoid. Again, getting an EMR system that's specific to your practice should make things easier. Learn how to use it. Have somebody in your office who's familiar with being able to use it, and then cross-train those folks. So if somebody's out, you don't run into a situation where one person who's responsible for making sure that your records are complete and compliant. If that person's out for whatever reason, you have somebody else who can step into that role. Again, the record keeping, I can't overemphasize how important it is to keep good records from the very beginning. Training all staff on documentation basics, encouraging flagging of issues, and again, making the compliance portion of the records part of what you do on a day-to-day basis, just like the treatment of the patients. You want to do the work, you want to enjoy and be fulfilled from the work that you're doing. You want to get paid for it. I don't know if we've circulated some handouts, but I have some handouts on some specific issues that you can look at as well. Maybe we'll talk about those depending on how much time we have at the end. All right. Contract and policy safeguards. How many folks that work with insurance payers read those agreements through? You probably sign the agreement, figure that you can't negotiate any of the terms in the agreement. And oftentimes that may be true, once in a while, depending on your negotiating leverage, you may be able to negotiate certain points in there, but you certainly want to have a good understanding of what is in the document. Sometimes when I do contract review for clients, it's not so much with the intention that we're going to be negotiating the contract. We know that we don't have much leverage to negotiate, although there may be a few points that we can do an addendum or something, something may be a deal breaker. We want to know about that and try to change it. There may be something in there, or a few points in there that we certainly want to be aware of so that if issues come up, we know to refer back to the contract or to the incorporated documents that go with the contract, the rules and regulations that are often available on websites or somewhere else. So we know what the guidelines are when it comes to requirements to get paid and to keep your money. The documents from the providers, and let's talk about private companies here. We're not talking about government necessarily. Those are in the CFRs and in the regulations. But with private payer companies, contracts are going to have all of your rights if there's a dispute over payment. It's going to have the appeal rights, where you send notice to, what is your time frame for giving notice, what are the payers' rights as far as auditing and recoupment demand, and then what are your rights to challenge that? What are the dispute resolution provisions in the agreement? You at least want to understand what they are before or when you sign your agreement with the payers, so that you have an understanding if something happens, what do you need to do? Again, some of these may not necessarily be subject to long negotiations when you sign agreements, but understanding where notice goes to, what the timeframes are, this is all very important when you're signing the contracts and operating under these agreements, to understand how you're going to use these agreements to your favor if you have a dispute. All right, I just said that typically a lot of these agreements we can't negotiate, but there are some issues that you can sometimes raise, either for clarification. Sometimes you can do it by addendum. I know the clients that I write contracts for that are used with a lot of other parties, we don't want the contracts themselves changed, but we have addendums and things that we can do sometimes if there's a particular term, especially again, giving your negotiating leverage, you may be able to modify specific terms in the agreement to avoid one-sided clauses, and these will be done through carve-outs or some other mechanism. For instance, let's talk about medical necessity. When a payer denies a claim for medical necessity, they're often applying their own internal guidelines, and those might differ from what a provider considers medically appropriate or medically necessary, depending on the provider's clinical judgment and on national standards. But here's the issue. There's no specific universal definition of medical necessity. So this is an area of dispute oftentimes when we're dealing with audits and recoupments. Payers often rely upon their own definition, which might be a proprietary or third-party guideline that's more narrow and more restrictive than what the provider is used to. So the providers need to understand which standards the payer is using, because that's the lens through which your documentation is going to be judged. So here's some examples of medical necessity standards. There's payer-specific policies where the insurer, such as United or Aetna, publishes its own clinical policy bulletins or medical necessity guidelines. And again, these are going to be more restrictive than what you are used to. There's the Milliman Care Guidelines, MCG, and these are used often by payers for inpatient admission criteria, length of stay, things of that nature. They're privately developed, and they're sometimes not disclosed unless demanded. So you don't even find out what the specific guidelines are until you're involved in a dispute. And these may be more advantageous, again, for the payers than for the providers. There's other standards, such as specialty society guidelines, up to date, that's widely used by physicians. These are more evidence-based and probably reflect more of the real world from what providers are used to. If your documentation is being judged against a payer's internal policy, but you're charting based on what's medically reasonable or medical necessity based on up-to-date or based on your own clinical judgment, you and the payer you're speaking two different languages. And so when you get into a situation, if medical necessity, by the way, going back to looking at contracts, sometimes it's not specifically defined in the contract. You'll just see medical necessity, depending on the company. That could be good. sometimes we try and get a definition of medical necessity, and that negotiation may backfire a little bit because you're trying to get specifics and you end up with specifics you don't like. But if it's a broad definition, you can always go back and try to make your own argument or take your own position on medical necessity, especially based on maybe outside experts that we would employ or that you would employ to define medical necessity. And then you can create essentially take that ambiguity or that vague reference to medical necessity and turn it to your advantage in a dispute. So you always want to ask, from the time you're looking at a contract and then later when you're dealing with audits and recoupments, by whose definition or what definition is medical necessity being judged? And when you know the answer to that, or when you have the ability to frame that answer, it helps you make your response and any appeals much more effective. Here's another term you need to be familiar with: incorporation by reference. What that means is I have a contract. It could be a 5 or a 10-page contract, something short. But if I have documents or materials, regulations, guidelines that are incorporated by reference, what that means is that the document referencing those particular policies are incorporated and considered part of the contract. Now, here's another spin or another rub on that. Sometimes you look at your contract and you see what the guidelines are, and you go out, and how many people go out and look on the payer's website and pull down a different policy guidelines or their additional manuals and look at those to figure out exactly what their contract says. Well, nobody really does that at a practical level. But here's a simple thing you can do when you're looking at the contract and when you're looking at the incorporated documents or the incorporated reference materials. Does the payer have the ability to modify those? And sometimes what we see is you'll have a contract that has a provision that says this can't be modified or amended without a signed agreement by both sides that the document's being amended. But then there's incorporated materials that are incorporated as of the time, whatever the most recent is. So it's materials that can be incorporated as amended from time to time. And when you see that, what that means is you've got a set contract and you think you know what the contract is, but now you've got all these other materials. And this typically, a lot of times, these are the auditing guidelines, the payment guidelines, your dispute resolution process, your appeal process for going through the audit. And those may be amended and updated from time to time. So you need to be aware of that language, and there's ways to deal with that with carve-outs. But I just want you to understand that that's the type of things you need to be focusing on when you're first looking at your payer agreements. What is the full agreement? And then when you go back, if you have a dispute, what do you need to be looking for to understand the full picture of what the rules are? Because that agreement and the incorporated documents and other policy materials that are all incorporated by reference, this is all the stuff that sets the rules for the playing field when you get involved in a dispute with a payer. Of course, there's all sorts of tools now that are being developed from a technology standpoint. Some people geek out and want to go look at that yourself, but there are there's consultants and folks that you can get involved that have a lot of experience in your particular type of practice that you may want to reach out to. I work with some. I'm very much a stay in your lane type of person. So if somebody asks me about this, I'm not going to do it, but I can certainly point you in a direction of someone that can help you identify additional tools from a technology standpoint or from internal self-auditing, consulting, cleaning up your policies, things of that nature. All good to do to make sure you're going to get rewarded for the hard work that you're doing. AI is a big issue. We may do a future seminar just focused on AI issues in payment and how you can really use that. Payers are obviously using that, but I want to show folks how they can use it to make their life easier and help you deal with these issues without it being a huge administrative burden. All right, so this statistic up here, algorithms that auto-denied claims in less than 1.2 seconds without a professional ever reviewing them. How often have we seen, have you gone through a situation where you respond to an audit, a request for records, essentially, you send the records in and you get a letter back and everything has been denied. And the denial reasons are often the same. You just see maybe there's 1, 2, or 3 different reasons, and that you've submitted documents on 5 patients, on 20 patients, on 100, and you get straight denials coming back. And it doesn't take that long for that to happen. As a human looking at those, or is there some flag that's popping up in the system? Dig deeper into those. there's a cost a cost versus reward or a cost benefit analysis that has to go on with some of this. But I just want you to be aware that the payers are using obviously these tools for their audits and to deny claims or to recoup money, and you can use those tools to your advantage as well. All right, so here's where we're going to dig into a lot of the meat. We've got a good half of our time to talk on these issues. What to do when you get the initial audit. You want to immediately start, you want to get it on the calendar. You want to give it attention right away. You've got a limited timeline to respond. Don't delay on this. It's very important that you move quickly, but you don't need to panic either. Get the letter, get with whoever your team members are, your folks that are going to help you gather the information you need to respond. Of course, one of the first things you need to do is identify who's sending the letter. And if it's a private company, it's going to be maybe from their SIU unit or some other type of review. Medicaid is often done through the state or through that payment error rate measurement program. And Medicare can come from all different sources. UPICs in particular, that's usually where you're getting in like fraud, potential fraud issues, things of that nature. All of them have different guidelines. If it's Medicare, you're going to go to the Medicare audit response and appeal guidelines. There's a 5-level system. Medicaid is typically going to be through your state. And then if it's commercial, through the special investigation unit, that's going to be in your contract and your policy documents. That's the first thing you need to understand. So read the letter, figure out the scope of the audit, look at the claims that are under review, figure out your time frame for submission. It may be stated in the letter and it may be in separate policy documents. By the way, especially for private payers, if the time frame seems short, don't wait until, if it's 30 days, don't wait till day 29 and ask for more time. If the time frame seems short, ask for more time right away. Send something to them. I've done this several times. We're working on a response. We're gathering all the information. We want to make sure our response is thorough and complete, but we're not going to be able to get it done by May 15th. So we're requesting an additional 14, 21 days, whatever. Anytime I've ever asked for that, I've gotten the extension, except for one time. And the one time that I did not get the extension was kind of a unique situation where I ended up getting the extension anyway, because oddly enough, and I mentioned this earlier, the payers write the guidelines. Their contract and policy documents had one time frame. The letter had another time frame, and those did not align. So, it was, it's, for lack of a better, more professional term, was like a jerky payer and representative. And they said no to my extension. I said, well, your letter doesn't even align with your own policy. So which one are we going by? And then they sort of backed off and gave us the time. All right. Obviously, I mentioned earlier, calendar the deadlines, put deadlines on the calendar, put reminders 5 days, 10 days out when you need to send stuff. Simple things, read everything carefully. Does your response have to be submitted by a certain time, or does it have to be postmarked by a certain time? When I'm responding to these things, I often like something where you can track the response, send it by FedEx overnight or 2-day. Make sure you give yourself enough time. For whatever reason, whenever I've dealt with, or often, I won't say whenever, but that's too broad. When I've dealt with federal issues at Medicare, it always seems like we send out something, we send it by certified mail, and it takes 12, 15 days to go through the mail system. I know the post office slows down when they're sending stuff to Medicare. Just be aware of what your time frames are. These are simple things. These are layups. You don't need a lawyer. Just look at the dates and make sure your stuff is thorough, timely, and complete. Audit types. These could be prepayment versus post-payment. Most of the time when I'm involved, this is the perspective I look at it with most of my clients. It's usually post-payment. The work has already been done. There's a record request that comes in, and it has to do with something that happened a few months ago, several months ago, maybe years ago. This could be just a routine audit, or they could be looking at something else. So you want to understand what you're looking at. And just because the work was done and you've already been paid, again, doesn't mean that they won't come back and try and ask for the payment. Doesn't mean they may not come back and try to not only ask for the payment, but ask for more through some type of extrapolation method. Extrapolation, that happens under Medicare. It's where you take a few folks who haven't been through that. You take a small sampling of claims, and they say, well, we looked at these 10 claims over this time period, these 3 months, and we see that you had a 100% or a 95% denial rate because these weren't medically necessary, because that's what they'll find. They'll find almost everything is deniable. So we paid you and we shouldn't have. And oh, by the way, since we only did a 2 or 3 month sample, we're going to assume that if you had a 95% error rate over 3 months, you must have had a 95% error rate over the last 4 years. So we want 95% of our money back for what we paid you over the last 4 years for these claims. That's extrapolation in a nutshell. I've seen private payers try to do it, and I've challenged it because I'm not sure that it's authorized for private payers unless they have something in their contract that says they can do it. And I haven't really had that turn into much of a battle because typically when we point that out, they back off. But again, that's why it's important to understand what kind of audit you're dealing with, because the rules are different for each one. All right, gather the records that are being requested. Typically, this is going to be and with electronic medical records now, it should be pretty easy to gather up all the records. But review the records, make sure that they're complete, make sure you're providing everything that's being asked for with respect to the audit, and document it. List out what you're providing. Okay, this claim, these records, this is what I'm providing. And the reason you're going to have that is you're going to put that into a cover letter that's going to list what you're sending, so you don't have to worry about the issue later, which invariably happens, that you send all the records and then the payer comes back, says, okay, we're going to deny payment for these issues, or we're going to request recoupment of payment for these issues because there's not complete records. And they say that records are missing, you sent the records. Well, what evidence do you have that you sent the records? You're going to create a log, and that log is going to have all of the records that you're sending. You're not going to send originals, of course. You're going to send them copies, but you're going to keep a copy of everything you send. You're going to have a log so you can easily reference that. There may be some issues, like signature issues. You can't modify the records. You can't change the records as they exist. But there are ways to correct certain issues. Signature is a very common one. If there's a missing signature, missing credentials of a provider, we can do that through a separate attestation or essentially a sworn statement that says it's not here, but this provider swears that they provided these services and these were the provider's credentials. So we're not modifying the records, but we're supplementing them. So understand the difference. You can't change the records, but you can supplement. And sometimes there are corrections that you can make that are very easy that solve a lot of issues that we see that come up from time to time. I kind of covered this already. Again, you're looking for, as you're going through and you're gathering up things up, is there documentation that's missing? Why is the documentation missing? Is it something that can be supplemented? Is it something that can be corrected without changing the file? And then as you're putting together the records and you're creating a log, as you see errors or issues in the records, things that might potentially be a problem, then we have to determine, okay, what can you fix? What types of things can be corrected? And then, what are the other issues? And if there are significant other issues, that might be your cue to reach out to your lawyer, reach out to somebody who knows this system and has dealt with this. Okay, we think we're going to have an issue here. How can we get in front of this? And sometimes there's ways to do that. It's just case by case basis. I already said, keep track of everything that you're going to send and then keep a copy of everything you're going to send. So many times I see clients send stuff out. I say, okay, what did you send exactly? And it's already sent and they don't know, or they send it with a cover letter that's not complete. I'm going to provide you after the seminar, if we don't have it in the materials, with essentially a checklist template you can use for a cover letter. All the things that you want to include. You want to have reference to all the to the claim, to the audit number, to whatever they're using for their reference, date, time, what you're sending, have it signed off by somebody in your office, the date that you're sending it, the mechanism by which you're sending it, if it's a secure link file that they provide, if you're sending it on a zip drive through FedEx. Again, we want to make sure that all this is clearly documented so it's easy to return to and know everywhere along the process exactly what you've done and how you've responded. When you're drafting your response, this is a business issue, and that's how you should view this. You've got, I refer sometimes to the business of healthcare. When you have bedside manner, things that we talk about when you're dealing with your patients and clients. When you're dealing with payers, it's somebody doing their job on one side of the table. You're just following along and doing your job on the other side. You want your tone to be respectful, professional, um, emphasize facts, emphasize compliance with the policy, medical necessity whenever you have to respond and explain anything. And then sometimes you may have supporting literature, external guidelines, things you may want to refer to support medical necessity. Typically not in the audit stage. This is really going to be more than likely, it's going to be something that comes up after the audit, but there are certain times when you may want to provide this information early on. I've got some examples here. I don't know that we're going to go through all of them, but let's pop into one here. So you get a denial based on medical necessity, based on the payer's policy. So I referenced this earlier. This is probably the most common one. These things aren't medically necessary, and maybe there's no explanation at all. It's just not medically necessary. And so the insurer denies, here's the scenarios. The insurer denies payment for an MRI, and you have an American College of Radiology guidelines showing certain red flag symptoms, and you may want to respond as part of your response to the insurer, if this is the particular issue you're dealing with some language like this that says according to the ACR appropriate as criteria, and make reference to that specific policy or document or reference point, and include that in the response that you send back to the payer. This often comes up. You may be dealing with this if you're asked for additional information, as I noted earlier. Most of the time when I'm dealing with this, it's there's already been service, there's already been payment. This is a post payment audit that I'm usually dealing with, although there's occasions where, because of a post payment audit, some of our clients get put on a prepayment review going forward. And then there's a denial here. So you may want to keep things like this in mind for situations where there's been isolated or specific case-by-case denials, and you have information to support the services that you're trying to get paid for. This will often happen when we're dealing with appeals. We all the time reference outside sources, professional publications, expert witness, testimony, and case law. There's sometimes we find cases that are on point discussing specific issues, something like signature attestations, something like oftentimes it's objective information where we can refer to other cases where things have been approved. And these are sometimes reported cases or ones that we have to dig a little bit further to find. What I mean by reported cases, it's lawsuits that have gone on appeal or some system of appeal where we're able to get records of the opinion of the court that made a final determination on these issues. All right, here's some other examples. I'm not going to go through each of these because I want to have enough time to cover all our material, but I want you to know that it's in here. There's some other examples here of situations where there's denials, where you can use outside literature, outside studies and reports to help support your use of or your service, and support payment for the service based on what you did, relying on outside guidelines. If you're going to cite literature in your appeal or in an audit response, obviously you want to use authoritative sources and keep it brief, cite to the source, give your reason, but you don't need to go on and on. You just cite it in the letter. And if there's further questions, they can go out and look at this specific site, look at the source of the information. On any of these situations, you're going to have further appeal rights, and sometimes a specific issue that you think is going to be an issue may not be. Something else may pop up, and you want to be prepared with an appeal to address the issues that are the concern for the payer in order to get you paid. I already mentioned providing a cover letter with an index when you send stuff back to the payer. Tone of the letter. Sorry if a little bit of this is a little bit redundant. I think I mentioned this earlier. Transmittal method. You want to follow it. Sometimes asked if I'm doing something right now where I'm responding on behalf of a client, and I just reached out to the other side who's asking for the information. Say, what's the best way to get this back to you? We're going to have it next week. You tell us what you prefer. I want to make things as easy for, think about this mindset. You want whoever's looking at this to be able to easily look at it and understand that you're entitled to payment, that the services that you provided were justified and you're entitled to payment. You don't want to make their job difficult. You want to make it easy every step along the way. If you look through that lens or that frame of reference, I think that will help you a lot in responding to a lot of these at the early stages. Tracking and monitoring, and then again, if there's some issue, if there's a medical necessity issue that's not clear, if there's a large recoupment demand, extrapolation, this is where you want to get lawyers involved. And then if you do have to, if you get denial, you get a recoupment demand, then we're going into the appeal process. For private payers, we're looking at the contract first, and then any other materials that are referenced in the contract. And again, because things can be amended or changed over time with regard to the outside materials, does the contract give them the right to do that? So you may be looking at a contract with a reference that has appeal standards or an appeal framework that's more beneficial 3 years ago than it is today. But if you signed the contract 3 years ago, there's a question here. Did the payer have the right and the authority under the agreement to modify those terms and put more stringent guidelines in place 3 years later? That's a contract interpretation issue. You may be able to figure it out, or you may want help from counsel. Look at this statistic here. This is crazy. 2022 government audit found that 75% of Medicare Advantage denials that were appealed or were fully or partially overturned, yet only 1% of providers ever appeal. People aren't going through the steps to appeal and make sure they get paid, even though 3/4 of the time these things can be overturned. I want you to keep that in mind when you're looking at this. Again, sometimes we see an issue, it's a $100 denial and it's not worth the time. But sometimes, even though things are a little bit smaller, you're dealing with, I've had clients in the past, it's sort of nickel and dime for 3-digit, low 4-digit, 300, 700, 900, $1,200 denials, post-payment denials where there's a recoupment demand. But then what happens is, okay, we're going to let that one go. We're going to let this one go. We get into the third, and then the frequency increases. Then the payer realizes, okay, we sent this demand, we got $500. A month later, we sent a demand, we got $700. 3 weeks later, next thing you know, you get a situation. I had this happen a few years ago where the client was close around COVID, where then all of a sudden, in the course of about 45 days, there's like 30 letters that come in. So you want to be aware of that issue. So sometimes there's a reason to, you don't want to ignore these. You want to deal with them and then be very strategic about how you decide, okay, maybe on a cost benefit, I'm not going to fight this, but there may be more than just dollars involved. All right, you get an adverse determination. You're going to evaluate it, try and identify weaknesses in the payer's position. Again, often coming down to some conflict over medical necessity, some conflict over clinical judgment. And you want to be in the best position to frame your argument around providing the services that were medically necessary. If it's other issues like you didn't get the proper referral, you didn't get you didn't get the proper person to sign off. If it's some technical issue, we want to take a look at that closely and see, is that an issue that can be corrected even though it's being identified now? Something like, and I've dealt with signature issues a few times. There's no signature, or the provider's credentials, or the start-stop times. I had another one. Start-stop times were not included, so we're going to deny payment. Well, we were able to go back and say, okay, start-stop times are not in a record, but we have these separate records from the telehealth system, and the telehealth system provides the start-stop times. We can print out these records, certify that these are the same appointments we have with the patient, and supplement the file. Will you allow us to do that? And that's what we said. Here's the records. Will you allow us to do that? Will that correct the issue? Got on a phone call with them. Well, if we are able to do this, will it work? And what are they going to say? No, they want to say no. But if it's reliable, if the information is reliable and it's not fraudulent, it's not something you're changing. It's just you had an earlier oversight issue that can be corrected with reliable, trustworthy documentation that can be supplemented. Then do it, and push towards that issue. Of course, I mentioned sometimes, depending on the financial impact, and other issues. Maybe you don't want to go through the appeal. Maybe you want to try and negotiate it out and walk away from part of it. This is a case-by-case decision. When you're drafting your appeal letter, some of the material I talked about earlier with reference to outside third-party sources, that's certainly going to go into your appeal. You want to summarize the issues, rely on facts, not your own opinion, rely on facts. And then when you're talking about medical necessity of treatment at the time that you provide it is now, and as you're looking back on it, that's a factual issue. That it's your professional judgment, but it's a decision that you made months ago, oftentimes, or that the provider made months ago. That at this point is a factual issue that the provider acted with the best information that they had available at the time. It may have not been a complete universe of information, but the best available information to the provider when they had to make the decision on the fly. And there is still case law out there from lawsuits that have occurred that says that the provider, that there should be some degree of deference to the provider because the provider is in the best position to make a determination of medical necessity. I forget the cite to the case, but I've used that in my own appeal letters, and it's still authoritative today, unless it's directly contradicted by some objective information. But that's often where your argument's going to occur, medical necessity. Then you want to go, oftentimes I like to take, okay, if there's a denial, here's the denial, here's the reason you denied, here's why that reason was improper. And it's like a bulleted outline. And then you have the next one. Here's the denial, here's the reason was denied, this is why that denial was improper, here's the information we have to support medical necessity or whatever it is, or whatever the correction is that you're providing. And again, okay, you denied this because you didn't have start-stop times, as I mentioned earlier. Now, okay, even if we don't have start-stop times, please see the attachment that's sworn to be correct by the attached declaration or attestation, and we've corrected that issue and we're entitled to payment. Professional, it's not adversarial at this point. You're just trying to make the other side understand that the stuff that you did was proper and you're entitled to get paid for it. Full chart notes. You want to, obviously, if you're going to refer to outside material, include good sources to that outside material or copies of it. If it's publicly available, you don't necessarily need to include copies. You just include a good citation. You can probably even Google, there may be a Blue Book or an AMA or some other way to cite to the material. If it's available online, put where it was referenced online, the last time you referenced it in case the link is broken. And to make sure you include all this, and your letter should list everything that you're including reference to, and same as when you're responding to the initial audit, date, time, good references, and keep track of the information and know where to send it. Sometimes we see in contracts the notice provisions, and for appeals, it's not clear if do we send it to the original audit address? Do we send it to both? When in doubt, send it to both, send your response to two different departments within or call if you can get clarification. Okay, where do we send this response? But you want to make sure that you're thorough to the point of exhaustive to make sure that you don't have something that gets overlooked again on some type of technicality. The common pitfalls, missing the deadline. I've seen that. Vague rebuttal. Don't miss the deadline. That's crazy. Don't miss the deadline. Don't fail to include copy reference or some type of reference to all the materials that you're sending. There's missed deadlines and incomplete materials. A good cover letter that lists everything that you are including in your response should cover that. So then you could say this was sent, it was tracked, we sent it by this mechanism on this date and time. Here's everything was included. If you don't have it, it got lost somewhere in delivery or on your end, but we sent it. And then you should be able to supplement with that information after the fact. I mentioned earlier that Medicare appeals have a 5-level process. They get, by the time you get to, we just did an ALJ hearing a couple weeks ago. By the time you get to that process, good idea to have experts, good idea to have counsel. You want to have professionals involved depending on the amount that's in play or that's in dispute. So if that becomes an issue, I certainly recommend you reach out to someone and get help with that. Medicaid appeals, these are state by state. In Florida, There's a process. Actually, there's a an alternative dispute resolution mechanism. There's mediation and an administrative system that you go through, and then through the payers. And here's another thing: a lot of the payers have a either voluntary or mandatory mediation and or arbitration process to go through. And so there's an opportunity early on to have a discussion and try to get these resolved. I'm very, very much in favor of alternative dispute resolution for these. It keeps it out of the public eye. If you can have a structured mediation conference, as a lot of folks know, I mediate these. I have a professional mediation practice that I maintain and align with my law practice. I'm hugely in favor of mediation. It oftentimes succeeds. You don't get everything that you want, but it very often provides a better alternative solution to resolving some of these problems. And if you can do it, try to do it at a very early stage so you keep costs down and use your time wisely. Track denials. I mentioned one earlier where I had a client who had, in the course of, I don't know if I'm getting the days right, this was a few years ago, but a number of document requests, essentially post-payment document audits that were requested within a very narrow window of time. It was like 45 days and there were 30 requests or something crazy. I ended up, we documented all the requests, and I sent a letter to the payer and said, how are we supposed to do this? How are we supposed to manage getting you all this material while we're running a practice? Can we get a phone call if we have a meeting? Can we have some guidance on what's an efficient way to do this? We're not adversarial, but we're asking, essentially, we're putting it into the payers, putting on their side of the table, okay, we want to comply with everything you're asking for, but how do we do it based on the volume or the number of requests? And we ended up getting that worked out. And actually, after that, we didn't get many audit requests. Maybe they turned their attention to somebody else. Another statistic, 58% of physicians say fighting insurance denials contributes to burnout, yet fewer than 10% have participated in payer policy feedback or advocacy. I don't know if that statistic is correct. I cite the source there. Final couple words here as we wrap up on reform and advocacy. There's a lot of frustration. So joining different medical societies and organizations, some that deal with these issues, as I mentioned earlier, certainly the payers, the commercial insurance companies, they have their own lobby groups, they have their own folks who are advocating on their behalf, and they're out in the public eye and say, no, we're trying to help the system and make sure the patients don't get abused. They're trying to maximize dollars for shareholders. Oftentimes, it's not to say that everything they do is bad, but you can become part of your own advocacy group. I won't spend a lot of time on this, but understand that there's some resources available state by state or depending on the type of practice that you're in. And I'd encourage you to participate in some of those to keep this from becoming a greater burnout issue on the provider side. All right, I think we're going to move through. I'm going to kind of finalize, wrap up, be prepared to take any questions. We're right at 1 o'clock. Look through these last couple slides. I really kind of put this in here as additional material if we got to cover it at the end. In the future, I'm going to take some of the topics we talked about and drill down in a more detailed level, step by step through a response letter. If you have interest in that, or if you have some other ideas, please let me know. I'd be happy to cover things that are of great interest for groups. And if you have a small group that would like me to come in and talk about something a little bit more in more detail, I'd be happy to consider doing that as well. I really enjoy this, and I think this is going to be a hot topic for the next several years. So we'll continue to be talking about it. Here's my contact information on the screen. For those of you who don't have it, you can reach me by email, you can reach me by phone, or on the website for the law firm, or on my mediation website. And if there's any questions out there, I'll be happy to field them. If you didn't get a chance to get your question in today, please feel free to shoot me an email or give me a call, and we'll try to address it as best as we can.